Good afternoon. Thank you for the opportunity to speak today. My name is Nichole Starr. I'm a general surgery resident at UCSF in my third year of research. I'll be presenting our work on perioperative provider safety in low and middle income countries during the COVID-19 pandemic. The protection of healthcare workers is of vital importance during the coronavirus pandemic. Surgical providers make up a part of this essential workforce. In high income countries, one strategy at the beginning of the pandemic was to postpone elective cases, to expand the supply of PPE and hospital beds, as well as reducing risk of exposure to providers. However, in LMIC settings, most surgical procedures are urgent or emergent, and those healthcare systems do not have the same luxury of canceling cases to redistribute resources. Additionally, supply chain disruptions caused acute on chronic PPE shortages in many LMICs, and with widespread vaccine availability being far off for many low income nations, the end of this pandemic is difficult to predict. In the early days of the pandemic, Lifebox and our partners developed a COVID-19 surgical patient checklist to function as a safety tool for surgical providers who needed to continue performing essential operations during the pandemic. This checklist summarized and operationalized the best practices around caring for a COVID positive or suspected patient in the operating room. However, the checklist assumes surgical providers have received training in infection prevention practices, have adapted protocols to COVID-19, and have material resources, including PPE and viral filters. We wanted to understand the current resources and processes available in low and middle income surgical hospitals during the pandemic to guide the most appropriate investments moving forward. To do this, our group distributed facility and provider level surveys inquiring about training received and protocols adapted to COVID-19, the material resources available, and perceived safety in the workplace. Ethical approval was obtained, and we distributed the survey in 9 languages via our partner networks and online. The responses were collected in October 2020, and we received 230 surgical facility responses and 507 provider responses from 63 countries. I'll present our results stratified by low and lower middle income versus upper middle income countries, which had different findings in terms of resource availability and preparedness. Most of the upper middle income country respondents were from Latin America and some from East Asia and the Pacific, whereas the majority of low income country respondents were from Sub-Saharan Africa and South Asia. About half of both groups had personally cared for COVID patients, but 35% of those in lower income settings felt unsafe at work, compared to just 7% of those in middle income settings. Upper middle income respondents had received significantly more training in COVID-19 OR protocols, PPE donning and doffing, and use of a COVID-19 surgical patient checklist, although there were gaps in both groups. Severe shortages of PPE were present in both groups as well, but worse in lower income settings, with 37% of low income providers not routinely having access to N95s, and 20 to 30% lacking routine availability of surgical masks, gloves, and eye protection. Furthermore, many providers were required to purchase their own PPE. In both income groups, over 40% of providers were purchasing their own N95 respirators. We also asked about reuse and reprocessing of N95 respirators. About 7% of both income groups reported reusing N95 respirators without any decontamination process. 20 to 25% of providers were utilizing appropriate methods such as UVC, hydrogen peroxide, or heat, and about 9% in the low-income group and 6% in the middle-income group were using methods known to damage and inactivate N95 respirators, such as alcohol soaking, bleach, or soap and water. We used findings from the surgical facility survey to identify other gaps in material resources. In 230 LMIC facilities, about 25% had no HEPA viral filters for anesthesia circuit tubing, and about 30% had a severe or moderate shortage of HEPA filters, meaning many procedures performed under general anesthesia would not have filtered exhaled patient air into the operating room, regardless of COVID status. There was also a shortage of pulse oximetry, with about 12% of facilities lacking a pulse oximeter for each operating room, and about 35% of facilities lacking pulse oximetry for each PACU bed, and a mean of 2 pulse oximeters for 5 PACU beds. We then performed a multivariate regression analysis of predictors of safety in the workplace, controlling for income level, hospital level, type, and location, as well as experience caring for COVID-19 patients. Training in PPE donning and doffing, use of a COVID-19 surgical patient checklist, and availability of N95 respirators were the most valuable elements, with each pertaining a greater than 4 times the odds of feeling safe in the workplace. The findings in the survey were intended to be rapidly actionable, and to that end, we published an early report to our partners and for public access. We also disseminated results via international collaboratives, including colleagues at the WHO, USAID, and large international donors. Country-level reports were generated and shared with our direct partner organizations, who could intervene in short order to address some of the most severe gaps on a country-by-country basis. We created an infographic to share results with social media and student communities in an attempt to generate more public attention to these critical provider safety gaps. In response, we at Lifebox have secured over $250,000 in additional funding for our COVID response in LMICs, including the provision and local production of PPE, pulse oximeters, and training support, and have an additional $1 million in funding pending. We developed an online PPE module tailored to the LMIC context and have trained about 100 providers to date and conducted 9 training of trainer sessions on a COVID-19 surgical patient checklist to over 100 trainers. Finally, we've hosted a series of webinars with a total of nearly 4,000 attendees. To conclude, the surgical workforce in LMICs is a finite and precious resource. They are necessary for the ongoing provision of emergency and essential surgical care to a huge portion of the global population, and are also human beings who continue to show up to work every day during a global pandemic, putting themselves and their loved ones at risk. We have lost many healthcare workers to COVID-19, and surgical and anesthesia providers in LMICs should and must have adequate training and protection to feel safe at work. As we feel the pandemic coming to a close in many high-income settings, we must double down on protection for healthcare workers in LMICs and focus our efforts in sub-Saharan Africa and Southeast Asia to protect these still vulnerable members of the workforce. Thank you so much to our large team of global research collaborators, as well as to our department at UCSF and our partners at Lifebox, SmileTrain, and JPIGO for supporting these efforts. Thank you, and I'll be happy to take any questions.